Hey everybody, James Weber here from the Public Safety Center in Harrisburg. So this is a quick screen-grabbed lecture series from one of our adjuncts, talking a little bit about neurological emergencies, a little bit about assessments, a little bit about how to actually, how to connect what you see in your assessments to the diagnosis, and some best practices for documentation. Should you have any questions, reach out to your program coordinator, and like always, enjoy.
Hello, everyone. This is Chapter 17, Neurologic Emergencies. This chapter is pretty interesting. We're going to be learning a lot about the brain, but we're also going to be talking about specific problems such as seizures, strokes, headaches, loss of consciousness, or level of consciousness changes. We're going to be doing some review of anatomy and also management of those problems. There's some really cool videos if you wanted to go on YouTube and check them out. There's videos of hemispatial neglect, on auras, on absent seizures, simple partial, and generalized seizures. So you can go on YouTube and check those out. There's going to be places later in this PowerPoint that those videos are inserted into. But go ahead and kind of explore on your own. It's pretty cool the things that you can find on the interwebs nowadays, especially videos, real-life videos about people going through those different things. So let's get this started here. Some review of the brain. We need to remember that there are three parts to the brain. We have, from the bottom, the brain stem, and then working up the cerebellum, and then the cerebrum. The cerebrum is the largest part of the brain. The brain is also divided into left and right hemispheres in the cerebrum. So the cerebrum is located above the cerebellum, and that's, of course, divided into those hemispheres, to two hemispheres. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum. The right hemisphere controls the left side of the body, and the left hemisphere controls the right side of the body. So each hemisphere controls activities on the opposite side of the body. The frontal lobe controls emotion and thought. The parietal lobe controls sensation and movement. And the occipital lobe controls sight. The temporal lobe does hearing, sound, and speech. The cerebellum is also called the little brain. It looks pretty tiny, and it's highlighted there in the picture. It controls muscle and body coordination. So it lets us do things like walking, writing, picking up a coin, or playing the piano. Brainstem. So this is the midbrain, the pons, and the medulla oblongata. It controls the most basic functions. So it has a bunch of different parts. The most important ones are the midbrain, the pons, and the medulla oblongata. These are all responsible for breathing, blood pressure, swallowing, and pupil constriction. So basically, the brainstem is going to be doing anything involuntarily. All of the functions that our body needs to do without us actively thinking about it, the brainstem is going to control that. All you need to know about this is that there are 12 cranial nerves, and they just send messages to and from the brain. Those 12 cranial nerves will run directly from the brain to parts of the head, and it will control the eyes, ears, nose, and face. So, for example, that olfactory will control the nose. The oculomotor will control the movement of the eyes. The trochlear nerve, nerve number 4, controls hearing. So let's get down a little bit south of the brainstem. We'll talk about the spinal cord. So the rest of the nerves join in the spinal cord and they exit the brain through the foramen magnum. It's a large opening. That's why it's called magnum. Magnum is large. Foramen is an oval or a hole. Two nerves branch out at each vertebrae in the neck and the back. So at each vertebral bone, two nerves will branch out. Those nerves carry signals to and from the body. And those are called spinal nerves. In this picture, it's actually depicted the cauda equina, which is a horsetail, and that's towards the way bottom of our spinal cord. And you can tell it kind of looks like a horsetail with all the fibers coming off of that. Those are all the different nerves coming off the bottom of the spinal cord. So let's start to get into some pathophysiology. So an infinite number of disorders may cause brain dysfunction, and may affect the patient's level of consciousness, speech, and voluntary muscle control. So different disorders might cause brain dysfunction. The brain is super sensitive to changes in oxygen, glucose, and temperature. If I can get anything across to you today in this PowerPoint, in this lecture, in this lesson, it's that the brain absolutely needs three things in order to survive. And that one is oxygen, the second one is glucose, and the third one is temperature regulation. The brain absolutely needs those three things, and it's super sensitive to any kind of changes. So low oxygen, the brain is going to have some alterations. The brain is going to become hypoxic and do weird things. If it doesn't have enough sugar, that means it doesn't have enough energy, and those signals can't get back and forth across the neurons. If there's a sudden change in body temperature, that brain is almost going to fry out and need to be started over again. And we'll talk about all of those things. A couple general rules that you have to keep in mind. If a problem is caused primarily by disorders in the heart and lungs, the entire brain is affected. But if the primary problem is only in the brain, only part of that brain is affected. So if something happens in the heart and the lungs, the entire brain is going to be affected. But if something happens in the brain, only the part of the brain is going to be affected. We're going to get into some disorders here. We're going to start out real simple. We're going to talk about headaches. And you might have one right now listening to me talk. But we have to remember that, yes, people do call the ambulance for headaches. We have to be able to tell the difference between a mild and severe one. And we do that by patient assessment and also interview techniques. So tension headaches are caused by muscle contractions in the head and neck, and they're actually attributed to stress. So a lot of times these don't require medical attention, but like I said, people call 911 for weird reasons, and that can be one of them. That pain might be like squeezing or dull or an ache. We've probably all had them. A lot of times it's going to happen between the eyes, all right? And you're just going to kind of try to rub that little area where your nose meets your forehead. Sinus headaches are caused by pressure as a result of fluid accumulation in the sinus cavities. So patients might have cold-like symptoms like congestion, cough, or fever, or they might actually sound like me right now. I don't have a sinus headache, but I have some sinus issues. So my voice is a little bit more nasally. That's one of the things that you can actually listen for when you speak to your patient. Patients might have cold-like symptoms. A lot of times that pre-hospital emergency care is not required. But like I said, sometimes people call 911 for reasons that are unbeknownst to us. Migraines are a little bit different, all right? These are pounding, throbbing, pulsating. These are severe headaches. And they're actually thought to be caused by changes in blood vessel size in the base of the brain. Patient might actually be experiencing vision changes, nausea, and vomiting. They might be light sensitive. They might actually have some GI problems along with it, like diarrhea. Um, they can also last for several hours to several days. Might actually have visual changes like flashing lights or partial vision loss too. So migraines are very tumultuous. They're very painful. And yes, people might call 911 if they've never experienced a migraine before. So how do we care for these people? So you have to remember that headache is a symptom. Headache might be a symptom that a patient experiences along with another problem, okay? So let's think of headache as a symptom, all right, not as an actual diagnosis. We need to be concerned if that headache symptom was sudden onset, that had a fever accompanying it, that they also had a seizure, some altered mental status, that AMS, or if there was trauma along with that headache. If a patient has a headache and they're having altered mental state, seizures, slurred speech, suspect stroke. And we're going to get into that in a little bit. Under number 2, increasing ICP or intracranial pressure might actually be caused by a hemorrhagic stroke or that bleeding of the brain, a tumor, or a recent head trauma. So, headache might actually be increasing intracranial pressure. What do? We give them a quiet, darkened environment if they have an altered mental state, if they're having a seizure, or if they're having stroke-like symptoms, you're going to call a medic. You're going to treat them with care and compassion, and just always be aware for other signs and symptoms that might indicate a more serious condition. So if your patient complains of a headache, they've had it for a few days, and they say, man, I just don't feel right, my balance has been off, think about that patient might have a more serious condition going on. All right, so let's get into talking about strokes. So, what is a stroke? A stroke is a cerebrovascular accident, or a CVA. So we kind of use CVA and stroke interchangeably. They are the same thing. A CVA is any interruption of blood flow and therefore oxygen to an area within the brain. It's going to result in the loss of brain function because you're not supplying the brain with oxygen, one of the 3 major things that the brain needs in order to survive. So if the brain's not getting enough oxygen, the cells are going to stop functioning and they're going to start to die. Why do we need to know this? Well, stroke is actually the 5th leading cause of death in the United States, according to the American Stroke Association. So some contributing factors for stroke include, of course, family history and medical history, race, of course, smoking, history of atrial fibrillation, and blood clots are also going to be contributing factors. African Americans, Hispanics, and Asians have a higher risk of stroke. There are some treatments available. There's medications that a hospital can administer. A lot of hospitals nowadays are certified or even primary stroke centers, and they're going to be able to give the patient special medication within minutes of arrival at their facility. So you have to be sure that you're transporting immediately into the appropriate facility. There are 2 types of strokes. First one we're going to talk about is ischemic. Second one we're going to talk about is the hemorrhagic. Ischemic is way funner to say, so I'm going to talk about that one first. So an ischemic stroke occurs when the blood flow through the cerebral arteries in the brain is blocked. So ischemia is the reduction of blood supply that results in inadequate oxygen. An ischemic stroke is when that blood flow is stopped because there's a blockage, and it could be from a cholesterol plaque buildup or a blood clot. So this is actually the most common stroke that you're going to find out in the field. 80% of strokes are ischemic strokes. And like I said, they're going to result from a thrombosis or an embolus. So the plaque buildup or a blood clot. It's going to block the blood flow. So sometimes your patient might portray very mild to no symptoms or complete paralysis and loss of consciousness. It can really go from mild to, oh my God, this is really bad. So I'd be remiss if I didn't talk about atherosclerosis. So we have some really fun terms in this chapter that I like to say. We have ischemic, and then now we're talking about atherosclerosis. Atherosclerosis is something that you need to know. It's a term that states that plaque is going to be forming inside the walls of the blood vessels. Okay? It's a disorder that calcium and cholesterol will build up. It's going to form a plaque. Plaque is super sticky. It's going to stick inside those blood vessel walls. That plaque might actually grow and obstruct blood flow and interfere with the vessel's ability to dilate. Eventually, if it goes untreated without medication, it's going to cause complete occlusion of an artery. So even if the blockage in that carotid artery is not complete, smaller pieces of the clot may embolize deeper into the brain and become lodged in smaller branches of those blood vessels, blocking the blood flow. So if we look at the picture here on our slide, this is the carotid artery, and you can see where the clot is. And the depiction in this slide here, where the deeper purple color is basically saying that that part of the brain is not receiving oxygen because no blood flow is happening beyond this clot. If there's no blood flow, there's no oxygen. If there's no oxygen in the brain begins to die. So we'll talk about hemorrhagic strokes. A blood vessel is going to basically rupture, and the accumulating blood in the brain is going to cause increased pressure. So it's going to be that ICP or intracranial pressure. The blood is then going to form a clot. It's going to compress the brain tissue next to it, and it's going to prevent that oxygenated blood from getting into the area. Those brain cells are going to start to die. Hemorrhagic strokes account for about 13% of the strokes, but these are the most harmful, and these are often fatal. So some people that are at risk include those that have high stress levels, or exert themselves a lot, prolonged extreme hypertension. Like I'm talking that their blood pressure is always over like 200 over 150, all right? Also, something else that can attribute to hemorrhagic strokes is patients that take blood thinner medications, okay? So we're going to talk about an aneurysm here. This kind of goes hand in hand with hemorrhagic strokes. So just stay with me for a second. What is an aneurysm? Well, if you look at the picture here, an aneurysm is actually a swelling or enlargement of the wall of an artery. So it results from a defect or a weakening in the arterial wall. And in this picture, you'll actually see that this aneurysm or this wall of the blood vessel has been swelled or enlarged so much that it's causing this to happen. So when a hemorrhagic stroke occurs in a healthy young person, it's likely caused by a berry aneurysm. So this picture is an example of a berry aneurysm. It looks like a sac or a berry, and it's going to happen at that bifurcation or the Y segments of an artery. Why? Well, it's actually where the most pressure occurs in the artery, is when there's a bifurcation. So these small berry-like projections occur at arterial bifurcations, or where that Y is. As you can see, this is the Y in the picture. And branches of the large arteries at the base of the brain. So this can also occur in the circle of Willis in the base of the brain. Some symptoms are severe sudden headache, nausea, vomiting, seizures, dizziness, and loss of balance. Decreased level of consciousness is also another symptom. Surgical repair might be possible for these patients, but they have to be seen immediately. So we're going to talk just about generalized bleeding in the brain. When patients may have high blood pressure, the hypertension, the HTN, which is hypertension, might be the cause of the bleeding. So you might have hypertension and then the bleed, or you might have the bleed and then hypertension. And that's basically a compensatory response. So a trend of increasing blood pressure is an important sign, as the body must increase the blood pressure to get blood to the brain's tissues. Significant drops in blood pressure might occur as the patient's condition worsens. So definitely get those baseline vital signs and compare your blood pressures that you're obtaining off your patient. Still talking about stroke here. This is the transient ischemic attack, or a TIA. So these are like little mini strokes. We also call them warning strokes, preemptive strokes, whatever. A whole bunch of different words and terms. Mini strokes is probably the more common term that you're going to hear. But mini strokes, they're basically when blood flow to the brain is obstructed due to that sclerosis or that blood clot, they might exhibit signs of a stroke. So it's a smaller obstruction in the artery. They might have stroke-like symptoms that are going to go away on their own in less than 24 hours. No actual death of tissue occurs with a TIA, all right, but it is still a definite medical emergency. TIAs are followed by more severe strokes. So according to the American Stroke Association, about a third of TIA patients have a more severe stroke within a year. And among patients who are treated for a full ischemic stroke, between 7% and 40% of them had reported having a mini stroke first. So up to 40% of patients that had a full-blown ischemic stroke had a mini stroke first. So if your patient is exhibiting signs of a stroke, which we'll talk about here in a second, and then all of a sudden they go back to normal, and then you see them do the stroke symptoms again, that's a mini stroke. Basically what's happening is that clot or that blockage in the artery is moving little by little. And it's occluding that blood flow and the oxygen to that part of the brain. So these some signs, and these are actually some examples of PSAs out there for stroke assessment for the general public. These are actually really helpful for us too. One of the most common ones that you're going to see is the one here on the left. It's FAST. We're going to look for face, arm, and speech symptoms. So in the face, we're going to look for an uneven smile like this lady. She's just not giving one of those cute crooked smiles. She's got a legitimate neurological problem. We're going to check if one arm is weak, and we're also going to listen for slurred speech. We're going to teach you how to do that here in a little bit. Time is so important, guys. Time is not only people calling 911 as soon as they see the stroke symptom, but it's our transport time, and it's making sure that we're taking them to the correct facility that's able to help those stroke patients. So like I said, we're going to look for facial drooping, arm drift. So you're going to hold the patient's arms out straight, have them close their eyes and hold their arms up on their own and see if one drops or not. Sudden weakness or numbness, like I just can't feel the right side of my body. Slurring of speech or aphasia. Lack of coordination in their muscles, which is called ataxia. Dizziness, blurred or double vision in one eye or another. So we're looking for something that's going to be like hemiplegia. And what we consider hemiplegia is something that's affecting one side of the body or the other, especially when it comes to movement. So if you have a stroke in the left hemisphere, it's going to cause problems on the right side of the body. Like we said in the anatomy in the beginning of the slideshow, anything that happens in the left side of the brain hurts the right side of the body, and vice versa. So in the left hemisphere, it's going to cause some speech problems and paralysis of the right side of the body. You need to know the difference between aphasia and apraxia. Aphasia is actually the inability to produce or understand speech. It's like you have something like on the tip of your tongue, you just can't think of the word. Aphasia always happens to me when I'm trying to complete a crossword puzzle. Like, man, I can't think of that name of that. Oh man, or you're trying to sit there and think of the actor that was in that movie. Oh, it's on the tip of my tongue. I just can't think of it. You can kind of attribute that as like an aphasia, all right? Apraxia is saying things that aren't actual, like, correct sentences. So if somebody says a cup of coffee, it might come out as puck a pappy, or I don't know, listen to me long enough and you're going to hear plenty of examples of apraxia. But it's just problems forming words. A stroke in the right hemisphere can cause paralysis of the left side of the body. And this is where we're going to start talking about spatial neglect. Spatial neglect is actually pretty interesting, and it's something that we have to think about in the back of the ambulance. So when patients have a stroke in the right hemisphere, they're going to understand language and they're going to be able to speak. Their words might be slurred, hard to understand, but they're going to have a problem with spatial reasoning, okay? They might also neglect certain parts of their vision. They might repeat answers even though a new question had been asked. So if you ask them, have you had a headache today? Or if you're asking an open-ended question like, are you having any pain right now? And they say, well, I'm having a headache. Okay. And then you move on and say, well, are you having any nausea or vomiting lately? And they're like, I have a headache. They're repeating answers even though a new question had been asked. Spatial neglect is actually ignoring one side of space. This is one of the cool things that you can look up on YouTube, and even just doing a Google search, you can give it a Goog, spatial neglect. There's a really cool video on theguardian.com, and it's titled Man Brain Ignores Half World. So he actually will draw half of a picture. So they'll ask this patient to draw a clock, and he can only draw the right side of it. He has no understanding that he has to draw the left side of it. That's a spatial neglect. When we're in the back of the ambulance, we have to be cognizant of a symptom similar to this. And that might include them unable to see you. So when you think about it, in the back of the ambulance, a lot of times we're going to be sitting on the patient's left. That's just pretty much where we sit, especially if we're in an ambulance. It's really the only place to sit is on the left side of the patient. Well, if somebody has spatial neglect, they're ignoring the one side of space, especially in the left side, all right? So they're not going to be able to see you. They're not going to be able to know where that sound is coming from because they can't see anything off to the left side. So just be aware of this and make it a little bit more comfortable for your patient. Move to the right side of them. Have a conversation on that side. Make them feel a little bit more comfortable about it. These are some conditions that might mimic stroke. So if we're doing a patient assessment and that we notice that patient has slurring of speech, they're basically weak, they're kind of drooling on themselves, we also have to take a look and see if they're hypoglycemic, if they have a low blood sugar. Stroke symptoms and hypoglycemia go hand in hand. And like I said, stroke is inhibiting the oxygen blood flow to the brain. When we have hypoglycemia, there is no sugar or glucose getting to the brain. All right, so you kind of see things going hand in hand already here with the three things that are keeping our brain alive. Another condition that might mimic stroke is the postictal state, which we're going to get into with seizures, and subdural or epidural bleeding. So that's actually when blood near the skull presses on the brain. So the picture on the slide illustrates intracranial bleeding. Trauma to the head might result in intracranial bleeding. So bleeding outside the dura and under the skull is called epidural, and bleeding beneath the dura but outside the brain is called subdural. So how do we treat our stroke patients? Well, get them to the hospital immediately, right? We're going to do supportive measures, all right? We're going to make sure that their airway is open. We're going to position their extremities, so we're going to prevent any further trauma. So make sure that if they're unable to control the one side of their body, that they're also not leaning towards that one side of their body. Suction if needed. You might have somebody that's drooling and unable to swallow. Oxygen therapy is not recommended unless the patient is in respiratory distress or is hypoxic. Okay. Sometimes with stroke patients, we're unsure if there's increased intracranial pressure, and high levels of oxygen therapy are actually shown to be distressing to those patients with intracranial pressure that is increasing. Continuously talk to that patient. Make sure that they know, or you're at least telling them what's going on. If they can't understand you, at least you're trying to tell them. And rapid transport to a stroke center. They need that thrombolytic therapy. So that TPA, that's a blood clot dissolving drug. And if it's given within 3 to 6 hours, it's really going to give the patient incredible results. Okay. Time is brain. We have to get them to a hospital immediately. With stroke victims, we're looking at anywhere from right around a 3-hour window. So from the time of onset or last seen normal to the time that they are able to provide the patient with thrombolytic therapy or any kind of mechanical therapy, mechanical methods, we're looking at 3 hours. That's a perfect time for the patient, that they will see positive results and get back to somewhat of a normal lifestyle. Aphasia. This is just kind of reiterating the difference between apraxia and aphasia. This is something that I just kind of like to go over with people, is that after a stroke, your patient might have symptoms of aphasia. So we do contact people that have stroke symptoms after their stroke. This is a normal baseline condition for them after their stroke. Aphasia, remember, is something that people are having a hard time getting the words out. Like the words on the tip of my tongue, I just can't think of it. This slide just kind of depicts on good things to do and how to communicate with your patient. So more people have aphasia than have many other common conditions. So more people have aphasia than people with cerebral palsy, than people with Parkinson's disease or muscular dystrophy or multiple sclerosis. Some other facts: about 1/3 of strokes will result in aphasia symptoms. And there are at least 2 million people in the US with aphasia. So aphasia doesn't always come from strokes. Aphasia can also come from traumatic brain injuries and other problems. Let's get into seizures here. Seizures are basically a neurologic episode. It's caused by a surge of electricity in the brain. So it can take form of a convulsion or an uncoordinated muscle activity, or it can be associated with a temporary alteration in consciousness. So in the US, it's actually estimated that 2 to 3 million people have epilepsy, which is a common form of seizures. Seizures and altered mental status can occur when there is a disorder in the brain. So seizures might happen as a result of a prior head injury, a brain tumor, a metabolic problem, fever, or actually a genetic disposition. So it can be handed down in the genes. So what happens during a seizure? Sometimes, not all, but sometimes patients might experience an aura. So an aura is just kind of like a visual change or a hallucination prior to a seizure. People that have auras, they recognize them, and sometimes they can take steps to like minimize their injury. So they're gonna be like, I need to lay down, or I need to get to a chair, or I'm gonna be going into a seizure. Or sometimes service dogs will be able to recognize a patient that's having an aura and be able to give assistance to them at that time. Auras don't always occur, and they don't always happen prior to every seizure. Not all patients with a seizure history have auras. Some other signs of an aura, like a feeling of deja vu, like this has happened again, or this has happened before and it's happening again. Sounds, smells, racing thoughts, dizziness, or strange feelings. All right, so you can actually get online and look up an absent seizure. An absent seizure was formerly called a petit mal seizure. There's actually a really good YouTube video of a small child having an absent seizure. So they might actually just appear to be daydreaming, and a lot of times the patient they'll have this episode just like kind of go out of it for about 10 seconds. They're going to fully recover. They might have a brief lapse of memory, but they're going to have immediate recovery. There's not going to be any kind of a quote-unquote postictal state, which I'll get into in a minute. A partial seizure is also called a focal seizure. A simple partial seizure, that's no change in the patient's level of consciousness, okay? They might have numbness, weakness, visual changes. Focal seizure is characterized by a lot of twitching or brief paralysis. So twitching like one way or another with the head or with the arm or with one side of the body, or some kind of brief paralysis. Again, you can look up a YouTube video of this. A simple partial seizure. In contrast, a complex partial seizure, this is when an altered mental state arises, okay? The patient's going to be a little bit more jerky. They're going to have like lip smacking. They might have eye blinking. This is resulting from abnormal electrical discharges from the temporal lobe of the brain. This is what we all know as seizures. So it's the full body. This is a generalized seizure. This is called tonic-clonic. This type of seizure results from abnormal electrical discharges from large areas of brain. This is usually going to involve both hemispheres. And the patient's going to be unconscious. They're going to have a generalized severe twitching of all muscles. It's going to last a couple minutes, sometimes longer. Some physical symptoms that go along with this: the patient can experience or exhibit tachycardia, hyperventilation, sweating, intense salivation. Most of these seizures are going to last 3 to 5 minutes, okay? And then after this, a postictal state of 5 to anywhere from 30 minutes to an hour, whatever is pretty much normal for the patient, is going to happen. And that postictal state is just basically the patient's recovering from it. So they'll go through the seizure, they'll appear to be kind of sleepy, or sleeping. They're going to be unresponsive at first, and then they're gradually going to regain consciousness. Sometimes they won't be able to speak at first, but slowly they'll be able to tell you their name, answer simple questions, and then they'll gradually become fully alert. It's actually pretty fascinating to watch. Of course, there is another YouTube video, a great one on this one too. So, like I just said, the postictal state. Once a seizure is stopped, the patient's muscles are going to relax. They're going to become flaccid, floppy. Breathing is actually, at this point, going to become labored. It's going to become fast and deep. And the reason being is that their muscles just went through this extreme workout. All of the muscles in the body were convulsing and twitching. So more oxygen needs to get to those muscles in order to recover. That breathing pattern, that also helps the body balance the acidity in the bloodstream. So this is actually from aerobic metabolism, if you guys remember that. With normal circulation, the patient's going to start to breathe more normally within minutes. In some situations, that postictal state might be characterized by hemiparesis, or the weakness on the one side. It might look like a stroke, so we have to kind of be cognizant that stroke and seizures a lot of times are going to be two different things, and two different symptoms and diagnoses. If the patient has a longer postictal state than normal, make sure that you're looking for hypoxia, that there's not enough oxygen to the brain. Also, see if the patient's sugar level is off, so get a blood glucose reading. And also look and see if the patient is hot to the touch. Again, the 3 different things that I talked about in the beginning of the PowerPoint slide that you have to remember the brain absolutely needs in order to function and survive: oxygen, glucose, and a regulated temperature. Okay? So make sure that patient is receiving enough oxygen, that their sugar level is good, and that they're not too hot to the touch. Your patient might also be combative during this state. It's best that you prevent any injury to them, and also make sure that you're being safe at the same time. They don't actually know what they're doing, so don't be angry with them if they're being combative or violent. And don't raise your voice. It's really not going to help the situation. Status epilepticus are seizures that are going to continue every few minutes, or just continuous seizures, more than 5 minutes long, sometimes longer than 30 minutes. If somebody is in a seizure for 30 minutes, they are definitely not getting the oxygen that they need to their brain. The acidity is building up in their muscles, and their whole body is eventually going to shut down. This is life-threatening, and you need to get them to a hospital as soon as possible. And you also need ALS on board. Your paramedic will be able to give certain medications that may or may not help stop the seizures in that patient. This is a table that was found in your book, Table 17-2. These are some common causes of seizures. So some common causes of seizures, like I said, could be an epileptic problem, so congenital in origin. They were born with it. The patient might have a tumor, an infection, scar tissue, head trauma, or stroke. Another common cause of seizures, especially nowadays, are drug overdoses. And we also do see this a lot in the field with sudden withdrawal from medications or alcohol. Seizures, most commonly in children, will be because of a sudden high fever, and that's called a febrile seizure. And this just reiterates the previous table. This is just a couple different depictions and examples of medications that patients with epilepsy or history of seizures might be taking. So these are some of the more common medications that are used. You will see Keppra a lot in the field on that top right corner. Phenobarbital is not as popular as it once was, but they definitely do use it in the hospital still. Dilantin and Depakote. Depakote and Keppra, Topamax, and Klonopin are a lot of the seizure medications that you'll see out there in the field. Those are super popular right now. So how do we deal with these patients? Well, we make sure that they don't hurt themselves, so protect them from harm. Make sure that their airway is open. If you need to suction, suction. Give them oxygen as soon as possible, okay? If they're all over the place and the mask is unable to be secured onto their face, then just make sure that you're providing them oxygen either by blow-by or nasal cannula. Also assess for trauma and immobilize if they need to be immobilized. Don't ever attempt to restrain a patient having a seizure. So you're not going to hold their arms down over their head. You might cause injury. You're definitely just going to put something soft behind their head so they don't smack their head off the floor. Sometimes you'll run into an event where a patient has a seizure that has a history of seizures, and they don't want to be transported to the ER because it's actually normal for them to have a seizure. It's usually in their best interest to be evaluated. If they are compliant with their medication, they should really be seen by a physician because those medications should take care of the epilepsy symptoms. So your goal is always to encourage a patient to be seen by a doctor. If they still refuse, definitely ask yourself questions. Are they awake, completely oriented, know exactly what happened? Is there any indication of trauma or any other complications from the seizure? Do they have history of seizures? Was the seizure usual in length? Did it involve their whole body? Do they usually have focal seizures and this one was a generalized seizure involving their whole body? Was their postictal state longer than usual? Any of those things that are abnormal, I would definitely get the patient to the hospital. The main thing that I can really tell basic EMTs, you guys going out into the field being brand new EMTs on the ambulance, is what you do is super simple. One, don't freak out when you get on scene. There's going to be people freaking out when you get on scene. Make sure that the patient's not harming themselves. Put a blanket behind their head. Make sure their airway is open and give them oxygen and call a medic. Don't really have to go into too much other detail. You're not going to be able to get a blood pressure off the bat. Just make sure that you're maintaining their airway and that they're not harming themselves anymore. So let's get into this whole AMS, or altered mental status. Any altered mental status is a result from an unexplained change. So, altered mental status. I don't know why, but Aunt Judy is acting super weird. That's an altered mental status. Bunch of different causes, but patient is basically not thinking clearly or incapable of being completely aroused. So in some cases, the patient's going to be unconscious, and others, the patient might be alert but confused. We're going to have to look at if the patient's intoxicated from alcohol or drugs, if there was a head injury, stroke, any kind of metabolic disturbances like a problem with sugar or glucose, hypoxia, head injury. You are going to want an ALS provider on scene for any patient that has an altered mental status. These are starting to talk about some causes of AMS or altered mental status. One of them is definitely hypoglycemia. All right. What are the 3 things that the brain needs in order to survive, guys? Oxygen, sugar, temperature. So one cause of altered mental status could be hypoglycemia, irregular sugar level, specifically a low sugar level. Patients with low sugar, they're going to have signs and symptoms that not only mimic stroke and seizures, but they might also have an altered mental state in that they're not really alert and oriented to what's going on. Another cause of altered mental status is delirium. Delirium, we have to remember, is a symptom. It is not a disease. Delirium is a temporary symptom. It's rapid alteration between mental states. So delirium can be caused by infection, a change in medication, or hypoxia. So sometimes your patient might actually come across as intoxicated on drugs or alcohol, or having a psychological issue or disorder, but they're actually having a legitimate symptom of delirium. How do we treat? Well, like I said, you're going to need a medic, and we're going to be treating the symptoms in this case, okay? If the patient needs oxygen or airway management, we're going to do that for them, all right? Other than that, it's going to be supportive measures. Let's get into a little bit of assessment and treatment in the field, specifically when it comes to neurological emergencies. So your scene size up. First of all, scene safety, all right? Patients with altered mental status, they might have a wide range of signs, symptoms, and behaviors. So make sure that they are not being combative, or make sure that they don't become violent. Don't be distracted by, like I said, the seriousness of the situation, okay? So if somebody is actively having a generalized full body seizure, flopping all over the place on the floor, calm yourself down, get a blanket behind their head, open their airway, give them oxygen. Move people on scene that are being volatile or overly frightened. This includes parents of small children. Frightened people, people that are yelling and screaming and crying, are going to be of no help to you or the patient, so clear them out. Make sure that you're looking for threats to your safety, and also consider the need for spinal immobilization, especially when we're talking about altered mental status and the possibility of trauma. Look for clues. You're going to determine the nature of illness. So look for clues like, well, Aunt Cindy's not really living in a very clean environment, and she also has a hard time seeing things. I don't think she's been taking her medications according to her pill bottles. They were filled back in August, and she should have had at least 4 other refills since then. Now she has an altered mental status. Observe that environment for signs of trauma. If somebody fell out of bed and on the floor having a seizure and now they're bleeding, Take a look at the nightstand. Take a look at the back of their head. Put two and two together that way. Take a look at their medical condition and medical history. Ask bystanders about that. And also look at any kind of medications that are laying around. Always ask the family when the patient was last normal. And this is especially important with patients that are exhibiting stroke-like symptoms. It's not necessarily when the symptoms started appearing, but when the patient was normal. So, if you have Aunt Cindy sitting in a recliner chair in the front living room, at 3 o'clock you check on her, you look back in at 4, she's taking a nap, you wake her up at 5 to come eat dinner at the dining room table, and now she's drooling on herself and unable to answer your questions. When was the last time that she appeared normal? Well, it wasn't at 5 when you woke her up, it was at 3 o'clock when you last had interaction with her. All right? So always ask when the last time the patient was normal. Gather information from the scene. I cannot tell you how important that is. Take a look-see around, all right? Get that rapid exam down. You should always, you should be able to tell if a seizure took place. At least to kind of take a look and see if the patient's postictal. You're going to use the AVPU scale. So remember the AVPU acronym is alert, responsive to verbal stimuli, responsive to painful stimuli, and unresponsive. During your primary assessment, we're going through the ABCs. So A and B, airway and breathing. Patients might have difficulty swallowing. They could choke on their own saliva, so make sure you have suction available. You're not going to stick that Yankauer suction tip all the way down in the back of their throat. Just put it around in their oral pharynx, or oral airway, just inside their mouth. You're going to position the patient to prevent aspiration. So if they're unable to sit up on their own, you can lay them in a left lateral position or a recovery position if there's no trauma indicated. Check for a foreign body obstruction. And all patients with an altered mental status should get high flow oxygen. And high flow oxygen, I'm talking about 15 liters non-rebreather. If they are not ventilating properly and they're unconscious, you're going to use a BVM and deliver a ventilatory breath over a period of 1 second at a rate of 10 to 12 breaths a minute. Don't hyperventilate a patient. Hyperventilation can have several negative consequences. So hyperventilation can overinflate the lungs. That can impair blood return to the heart and cause decreased cardiac output. Hyperventilation can also increase the risks of regurgitation, so actually vomiting, and abdominal distension and gastric distension, and then aspiration of that vomit. Hyperventilation can also cause severe injuries in patients that have head trauma with increased intracerebral pressure. So, make sure that you are giving appropriate oxygen therapy to these patients. For circulation under your primary assessment, make sure that the patient has a pulse if they're unresponsive. Check and see if that pulse is regular or irregular. And always ask if irregularity is normal for the patient. If the patient's responsive, just kind of look and see about their skin as well. Are they sweating? Are they diaphoretic? Are they pale, cool, and clammy? Is the pulse fast or slow? Are they tachycardic or bradycardic? Is it weak, thready, strong, bounding? Are they bleeding? These are all important questions to ask and look. Establish your transport decision. With patients with neurological emergencies, it's going to be a rapid transport. to an appropriate facility. Chief complaint during your history taking, just make sure that if the patient can't answer you, it doesn't necessarily mean that they don't have any complaints. Patient is unable to communicate would probably be a better chief complaint. Okay. If no one's around and the patient's unable to communicate or they're unresponsive, look for explanations for the altered mental status. So you're going to look for stroke. So you're going to look for weakness on the one side, facial droop, excess drooling, inability to really communicate. Seizure. You're going to always look for incontinence of the urine or the bowel. Look for a bitten tongue, bump to the back of the head. And evaluate that patient's speech, arm drift, facial droop. Ask family when the patient appeared normal last. I can't say this enough that time is super critical, especially in a neurological emergency. So always make an effort to determine the exact time the patient appeared last healthy. Okay? Always ask about when the patient last appeared to be healthy. Get medications, ask if the patient has any history of seizures or stroke. With stroke, ask them if they have any history of diabetes, atrial fibrillation, blood clots, hypertension, high cholesterol. Those are all very important questions. And always ask if this episode, whether it be an altered mental state or seizures or anything like that, how that episode was different from previous episodes, especially if the patient has a history of it. Let's get into the Cincinnati Pre-Hospital Stroke Scale. This is what you're going to be doing in your patient assessments from here on out, whenever you suspect anybody that has a neurological emergency. This should be done on any patient, okay? This is called our stroke assessment. This is the Cincinnati Pre-Hospital Stroke Scale. This stroke scale is actually able to rapidly identify stroke in the field. Okay, so this is what we use in the ambulance. Kind of already gone over the whole FAST concept with facial droop, arm drift, and speech abnormalities. That's exactly what this is going through. So stroke scales are going to evaluate the face, arms, and speech. There's a couple different kinds of stroke scales. The first one is Cincinnati and the other one is Los Angeles, but the Cincinnati is definitely more commonly used. To test speech, you're going to just simply ask the patient to repeat a simple phrase. So you're going to say, "Can you repeat back to me that it's always raining in Pennsylvania?" Which it is, by the way. And the patient will hopefully say that back to you normally and without any slurring or using inappropriate words. To test facial movement, you're going to ask the patient to smile, showing their teeth. So make sure that they're actually showing their teeth. They're not just giving you this gummy smile. All right. I'm going to have you smile at me. Can you smile real big? Nope, show me your teeth. And they'll usually be like, "Oh, that's weird," and they'll start to smile. You're going to look for kind of like a abnormal response of where one side of the mouth isn't actually moving as much as the other one. That's called facial droop. To test arm movement, you're going to look for arm drift. So you're going to ask the patient to hold both arms out in front of their body, think like Frankenstein, but palms up towards the sky. You're going to have them close their eyes, and you're going to say, "I want you to hold your hands up while I take them out." Keep your eyes closed, and if you do that and one arm moves, that's usually a abnormal response and a positive sign of stroke. Okay. The Los Angeles pre-hospital stroke screen is different in that it's going to take into effect the age of the patient, how long their symptoms had been going on, any kind of medical history, And also they're going to do facial droop, arm drift, and they do grip strength. The 3-item stroke severity scale, or the LAG, it looks specifically at 3 items, so it's going to look at level of consciousness, arm drift, and gaze. When the patient is admitted into the hospital, or when the ER doctor or neurologist is doing a full stroke assessment on the patient, they're going to actually take a lot of these things into consideration. So they're going to give a patient a word to say or a word to remember. They're going to have a short conversation and ask them to, repeat the word that they asked them to remember and see if they're able to remember it. They're going to be doing some gaze things. They're going to be doing a lot of history, like on the Los Angeles pre-hospital stroke scale. They're going to be doing grip strength. So you need to know the Glasgow Coma Scale. So my suggestion for you is to memorize this. There's a whole bunch of ways that people can memorize this Glasgow Coma Scale. You can find a lot of them online if you just give it a Goog. Literally just type into Google how to remember Glasgow Coma Scale. You can memorize it. You can use bathtub chalk and actually just write it inside your shower, so you have it to look at, hopefully when you take a shower every day. You can do a lot of different things to try to memorize this table, but you need to know the Glasgow Coma Scale. We're going to make a lot of our transportation decisions based on the patient's GCS. The GCS is an indicator on how well the patient is performing at simple life tasks. So eye-opening, verbal response, and the motor response. So if you take a look at this table, if a patient is dead, so we have a deceased patient, like I'm talking like dead, all right? They're not opening their eyes, they have no verbal response, and they have no motor response. They still receive a 3 on the Glasgow Coma Scale. The dead person receives the same GCS as somebody that is completely unconscious. So just keep that in mind, all right? If you have a patient who's exhibiting stroke-like symptoms that is alert but unable to speak and obeys commands, so they have a 4 for eye opening, they have no verbal response, so they have 1 for that, but they're able to follow commands and stand and walk for you, that's going to be an 11 on the GCS scale. 8 or less on the GCS scale is indicative of a severe dysfunction. 9 to 12 may indicate moderate dysfunction. Completely normal is 15, okay? But you might also have a patient that's normally a 13. It's really advisable for you to ask what the patient's normal baseline status is when it comes to verbal response and motor response. A Glasgow Coma Scale level of a 10 might be normal for somebody that is in a vegetative state, okay? So during our reassessment, we're going to be definitely focusing on the ABCs, making sure that the patient still has an open airway, they're still breathing correctly, and they're not bleeding. We're going to look at their vital signs, and we're going to take a look at the interventions that we gave the patient. Is the oxygen helping them? Stroke patients can stop breathing without warning, so make sure that you keep that in mind and keep their airway open. Always compare changes. If an intervention's not working, try something else, okay? Communication and documentation of these patients, of any patient with a neurological emergency, but specifically one with a stroke symptom, you have to go to a designated stroke center. So make sure that when you get working for the companies that you're going to go work for, that you know where the designated stroke center is, the one that's closest to you. You're going to want to call in a stroke alert for your patients that you have assessed and found to be having a stroke, or you think to be having a stroke. Make sure that you communicate, if you have to call into medical command prior to that, that the time that the patient was last seen healthy, that you are also sharing the findings of your neurological exam and any changes. So that Cincinnati stroke scale, do it once when you first get to the patient. Do it also if you notice any changes during your encounter, but also do it right before you get to the hospital to see if there's any changes in their neurological condition. For patients who have had a seizure, give a description of the seizure activity if it's known. So if the patient had a full body seizure, call it a generalized seizure. If the patient had like focal-like symptoms, you're going to call it a simple partial. Okay? Always document, document, document. So that's the end of this presentation on neurological emergencies. As I said before, these are going to be a lot of high energy, high anxiety scenes. It's important that you remain calm and know that you as a BLS provider have to worry about airway and circulation and making sure that the patient doesn't hurt themselves anymore. Okay? So keep their airway open, give them oxygen, get the information that you need on scene, call your ALS provider, and go en route to the most appropriate closest facility. That's all I have to share with you on this one. Thanks for listening.